Well, it's really a delight to be here in sunny London today. And so let me just get a sense of who's in the audience. How many people are clinical? Okay, how many people are doing research in palliative medicine? It is the best time, because I can almost guarantee what we have is a paucity of research and so many things that we need to investigate. And we are going to live through turbulent times in the next decade, I think over here as well as in the US, that we are, as a specialty in a field, are really going to mature over the next decade. And so if you're doing research, it's a great time to do it because there's so much that we need. So I'm going to present somewhat of a US perspective today. So I have to explain to you this very bizarre benefit we have, which is called the Medicare Hospice benefit. I'm going to give you as little as possible as I can give to you about the confusion of how we pay for care. I'm going to talk a little bit about the whole notion of geographic variation research. And then I'm going to start presenting some of the public data that we have on variation in hospice, and then start thinking about how we should be confronting our hospice variation and how we as researchers should start thinking about how we're moving forward with an agenda that takes care of the future demographic imperative of an aging population. We're all going to do that in 50 minutes. Hopefully I will leave some room for questions, and you can feel free to agree, disagree, or whatever. So 101. It's always great to know how an act gets passed in Congress. And usually what they do is they take something and they slip it into a bill that has to be funded. And each year, we have to have a tax law passed. So as part of the 1982 tax bill, in between two amendments to the IRS, they actually put in the Medicare Hospice benefit. And this was a very controversial benefit to put in. Some of the early hospice innovators did not want the government to pay for hospice because they were concerned it would remove the voluntary nature, and once someone pays for something, they can decide what services you provide. And they were very concerned that a concept that was born completely outside of mainstream medicine would now become medically dominated. So this is from one of the original reports. And the reason I always put this slide up is it talks about not only humane, but it talks about cost effective. And in the original hospice benefit, we have something that's called a capitated rate per patient. And what that basically means is a hospice in aggregate cannot receive more than the cost of the last 6 months of life on average per patient. Based on a figure figured out in the early 1980s, it was originally around $6,000 per patient. It's now up to about $22,000. If a hospice exceeds that cap, they have to return that money to the US government. Okay? So there are hospice programs that have exceeded the cap, and they have to pay back millions of dollars. So from the beginning, they said, listen, we're going to put some limits on how much you can charge, and we want to constrain this growing movement. So now, current thing in the US is people want to reform how hospices are paid. So, you know, if you look at our data, nearly half of people are enrolled in hospice. That should be a good thing. We should be celebrating that. Well, there's a little entity we have that's called the Medicare Payment Advisory Commission, or we call it MEDPAC for short. And MEDPAC has been consistently, report after report after report, saying too many for-profits, too high of a profit margin, too many fraudulent cases. Okay? So these are cases, for example, currently the headlines in the US now, Wall Street Journal is a for-profit corporation who is accused of billing for services they did not provide. And one of the services we'll be talking about is continuous care. Then MEDPAC also has said the per diem visits, in other words, how hospice is being utilized, is not reflective of how much it's paid. So let's step back for a second And let's just talk a little bit, we'll talk a little bit about payment in a second, but I just want to show you the growth. So 2000 to 2009, we had a doubling of people on hospice. So it went up from 513 to 1 million. Total spending was 12 million in 2009. 2012, it's $13.8 billion. $13.8 million, I'm sorry. So, no, it's no billion. 13.8 billion. Roughly, that's around about 2.5% of our total healthcare spending. Average length of stay has gone up. Now, the interesting thing about hospice is we very much have a bimodal distribution. A lot of short stays, a lot of 3-day wonders, and a lot of long stays. And it's the long stays that everybody's concerned about. So, one of the things that is collected on our bill for us to get reimbursed by the government on our bill is information that is what services you provided on a daily basis. So if I go out as a physician and I visit someone, I have to start a clock and say how many minutes I was in that patient's room. So you have information that's on who is seeing the patient and the duration of time. When you have that information, essentially what you're doing is a time and motion study. And here's what they've done. They have the results of that time and motion study stratified by length of stay. And what they've seen is they've calculated the amount of wages that's spent on a daily basis, and they show that it's quite high in the beginning. As you trough down to sort of getting everything in place, stays low, and then goes back up at the end. They call this the U-shaped curve. Some people like to refer to it as a hanger because it goes down like this. So this is the recent MEDPAC report that was released as of last week. And what's really interesting about this is it now starts giving the labor cost of visits per day. So when you're in that flat section of the U, it's about $15 a day. So you can imagine that, they will now give relative weights to this to come up with a new per diem rate, which would reflect the intensity of services. So early on, the weight is nearly 2 times for $254 a day for those first few days. As you start getting down into these days where there's less intense services, you're now talking about a 14% reduction. So you can imagine that if you have a hospice program where you're doing a lot of visits among people for long lengths of stay, and you start adding those up, you can get a rather substantial reduction. So one hospice was very upset because they actually simulated it, and they said, we're going to get a 40% reduction in our revenues based on this U shape. Well, there's being a message that clearly this sends is they don't want people who are on for long lengths of stay on hospice services. If you read the mantra for the Center for Medicaid and Medicare Services, they believe very firmly they do not pay for custodial care. They pay for skilled services only. So from their standpoint, they want to incentivize skilled needs and not to incentivize custodial care, and their concern is that this benefit is sometimes being used for custodial care. So if you're a policymaker and you want to change how things are done, here's the options that we have to do in the US. And a lot of this is all the dream child of health economists. You can change the payment. You can change the regulation, audits, surveys. You could add co-payments. So in managed care, they've done a really wonderful job of decreasing costs in managed care by adding a small co-payment per visit. Decreases MD visits. You can change how you define the benefit. You require prior approval. And then what we're going to be exploring in the future is this whole notion of value-based purchasing. And under value-based purchasing, there will be a base rate you would receive and an incentive pool. And the incentive pool would go to those people who achieve the highest quality. So talk a little bit about regional variation. I just want to give you one more fact here. When we bill for Medicare Hospice, we bill either on a day which is a routine day, which is about $156 per day, or we bill at a level of general inpatient care, which is a facility-based, which is about $629 a day, continuous care in the home, which means you're providing at least 8 hours of services, can bill out at around $2,500 per day, or respite. Respite is hardly ever used. It's much lower rate. So regional variation. So one of the people I had the privilege of working with is Jack Winberg. And early on, Jack Winberg was a public health doctor who was raising his children in Vermont, and he noticed one town in Vermont had a tonsillectomy rate of 7%, and another town had a tonsillectomy rate of 70%. And that really was the birth of trying to understand why there's substantial variation. We've done some work on feeding tube insertions, which I can present to you a little bit, and we also have done some work on regional variation in hospice. So early on, I can remember one of the first days of my internship, I was sitting there at 4:30 in the morning, just getting to know my patients, and my attending came in around 5:30, still up, still writing up admissions from last night, and I said, you know, I think I want to get a neuroconsult on this patient. And he said to me, well, if you get a neuroconsult, you're going to get an EEG, LP, and a CT scan. And the same thing, you know, early on that made a huge impression because no matter whatever you consulted them, they always had the same 3 things done prior to them even seeing the patient. So that came to my law. If you go to Midas, you get a muffler. Midas is a muffler shop in the US. Or my favorite corollary to that law is if you call GI, something will be scoped. So the powerful role of financial incentives in the US is, you know, something will be happen. Now, it seems to us these areas of very sort of intense, high ICU utilization is all below what we call the Mason-Dixon line in the South. Okay, so here's the current set of hypotheses: fried beer and different illnesses, race and preferences. African Americans are more likely in the South. The field of dreams hypothesis: if you build it, they will come. Because in the Deep South, there's no certificate of need. By states, if there's no certificate of need, you can build it, you know, just put it up. Or those who said studying the dying tell us nothing about the living, and it's a type of methodology that should not be utilized. That's the Bach argument. So let's just take a quick look before we talked about hospice, just talk a little bit about feeding tubes. So Tom Finucane, great guy, 1999, took the best available evidence and said, listen, why are we putting feeding tubes in all these people with end-stage dementia? We're not improving survival, we're not healing pressure sores, we're not preventing aspiration pneumonia, and we're not improving their quality of life. And indeed, there was actually a GI editorial said, we need to do a randomized controlled trial of feeding tubes. And so we quickly responded and said, no, you don't need to do a randomized control trial of feeding tubes. We did a propensity match cohort study and found no difference in the survival, feeding tube versus non-feeding tube, and had a really good match. So no, we really don't need to do RCT. Feeding tubes are not associated with improved survival. And Susan Mitchell, who's one of my close colleagues, we finally got the ABIM, and we got 3 organizations, AHHPM, AMDA, which is our American Medical Directors Association, and American Geriatric Society, all on page of saying one thing: do not insert feeding tubes, offer comfort feedings, offer hand feedings. This is sort of something that we're doing that doesn't make a lot of sense. There's not a lot of outcome data to support it. Yet, this is the regional variation. Remember, where there's a lot of ICU utilization, you know, it's this Deep South. I have made the bad joke several times, which I'll continue to make until someone tells me to stop making it. We can solve our regional variation problem if we give Louisiana, Mississippi, Alabama, Florida, Texas to Mexico. And then they can have their data, and then it gets much, much, much better. But you know, here you have the rate of feeding tubes among people with severe dementia varying from 3.8 to 44.8%. It's just ridiculous.
You have to give them California as well.
Yeah, part of California, only the southern part of California. The northern part of California is pretty much on the mark. So we did a prospective study and we said, Yep. Even when you look at the data prospectively, follow a cohort, all with the same severity. There's striking variation in the use of feeding tubes. You know, and indeed, 12% of hospitals over an 8-year period put in no feeding tubes. 25%, 1 in 10 chance. 2 hospitals in the same city, okay? And this is one of the hospitals who bellyached as so much about the Dartmouth data, had a feeding tube rate of 13.3, while the other hospital, which is exactly less than a mile away, had a feeding tube rate of 3.3 per 1,000 people. So that's obviously Cedars-Sinai. Now, their argument back to me now is we take care of only Orthodox Jewish people, which may be true. But we decided to do a survey and say, well, does this really reflect patients' informed preferences? And so we looked at my 3 favorite southern states, Texas, Florida, and Alabama, and we said, tell us about the process of informed consent and feeding tubes. Well, first of all, I made a very sophomoric mistake. Okay, I just assumed when you were putting a feeding tube into someone, which involves putting, you know, trocar for your stomach, getting informed consent would be something you'd have to do. I didn't assume that anybody would do it without getting informed consent. Well, it turns out 10% of the cases didn't have informed consent. You know, I said, quickly, pull all those surveys. What's going on here? And indeed, there's notes from the interviewers on the side. We just walked in there and someone had put in the feeding tube without asking us. Half of them said the conversation was under 15 minutes, and usually the conversation was 5 minutes. Third said didn't discuss the risks. Half said doc strongly in favor. 13% said they felt pressured. And a fourth regretted the decision. I'm surprised not more. So clearly, this is not a process of informed consent, which looks like people are really doing shared decision making and people are inserting these feeding tubes to reflect patient preferences. And furthermore, people are bothered by them, people are physically restrained, and people are pharmacologically restrained. So I actually went out on a limb and said, listen, this is ridiculous. We need to do something about this. And that the decision to insert a feeding tube in a nursing home resident with advanced dementia is more about which hospital you go to than a process of informed consent. So I pretty much strongly went out there and said, it's about variation. We got to confront our variation. You, my friends in acute care hospital, must do a better job. So now those words are coming back, and I have to confront our own variation in hospice. So GIP. GIP stands for General Inpatient Level of Care. Now this is probably a very poor acronym because the word GIP in US slang means that it's sort of fraudulent. It's bad care. It's, you got gypped on that deal. General Inpatient Care Day is a day where someone has hospice who has such difficulty with pain control or symptom management that it cannot be managed in their current setting, and they need to have intensive staffing around the clock to manage it. It's meant to be time limited. Similar for the thing continuous care. Continuous care is really periods of crisis care where services provided at the home. It's meant to be only short term to allow persons to stabilize and be discharged. Now, what VITAS was recently accused for was providing the service without any documentation. They billed for it, but they didn't deliver it. And that's what is getting them into trouble right now. Or the Department of Justice said that they billed for it, but the patient did not have the need as documented in the medical record. This is all about to probably go to trial. So between 2000 and 2009, we saw GIP go from 3.9% to about 11%. In that same time period, what we saw is where GIP was provided flipped, okay? So 11.3% is either acute care hospital or in a freestanding hospice inpatient unit. Right now, in 2005, majority was in an acute care hospital. 2010, 11, as we go out, it's nearly 2/3 of this rate is now provided in a freestanding hospice inpatient unit. Why? We built loads of freestanding hospice inpatient units in that mid-2005 period onward. Everybody had to build a freestanding hospice inpatient unit. So, if you look at the variation in average GIP days, I actually first analyzed this as part of another project, but when I looked at it, I saw that it varied from 6.4% to 50.3%. The state with the highest rate of GIP was Rhode Island. I immediately looked at this data and I knew that we have this little entity called Office of Inspector General, or OIG as we like to call it, and they're the people who goes out and looks for healthcare fraud. They had one of their work orders for that year to look at GIP use. And I looked at that rate in Rhode Island and I said, OIG is going to be at our doorsteps. And indeed, they spent about a year with us in the entire state. And the state had to, because it's in charge of enforcing some of these rules and regulations, had to return money back to the OIG, as well as some hospice programs may have to return some money. So I've always, in giving these talks, I tell hospice programs it is not good to be in the top decile of anything or in the bottom decile of some things. So be careful. But here we have a tremendous variation in the use of GIP, okay? Then we also looked at where GIP is provided. Well, this is another case where it's not good to be in the top variation. In Rhode Island, we had 26% of people who had hospice in a nursing home having GIP level of care, compared to our lower rates, 8.6% in Connecticut and 8.9% in Massachusetts. Again, believe me, another reason why we had OIG hanging out and reviewing 300 charts. So I really have gone on the line and told hospitals you have to confront their variation. We have to confront our variation, and we have to ask the question, is this the right care for the right persons at the right time in the right place, and is it associated with honoring that person's right to participate in medical decision making? So this is one of the things I did at a meeting of hospices, our national meeting. I said, this is the benchmark. And when you look at this benchmark, 25% of hospice programs have no GIP use. I'm a little bit suspicious that that's poor quality care, okay? These guys out here, cut me a break. 55% of people having GIP care, I have to be suspicious that someone is GIPing everybody. So we have one of these bimodal distribution problems, and it comes down to fundamentally, what is the right rate? Because the right rate is not 0. Okay? Unless you're not taking care of actively dying patients. There's always someone who needs a CAD pump, who has a complex pain syndrome. But the right rate can't be in the high 60s. So here's what I told hospices to do, and we're creating a data audit tool for them. But if you have a rate of 0, take a look at your family evaluation of hospice care scores for people 3 days or less, see what they are. Do a chart audit in the last 3 days of life. Examine your concerns and complaints. Do focus group of people who died shortly after hospice stay. If you have a GIP rate of 0, I strongly suspect that you have a problem with the quality of care. It can't be a 0. If you're above 30%, are you anticipating problems? Do you have the right rescue medications in place? Are persons getting placed on GIP prior to doing first-line changes in medications? So in the US, just because someone has pain, you can't put them on expensive care. You have to prove to them that first-line treatment does not work. So you just can't start someone on opiates and throw them on GIP. That would be considered fraudulent care. Is there an intensity of services that justify GIP? So are they changing medicines? Are they changing treatments? Are they making the visits for those that are in a nursing home? And is there a severity of symptoms? So monitoring does not equal that you continue someone at a low level and don't make any medicine changes for 5 days. It becomes very suspicious. And I really think it's very important to ask, if you have a high rate of GIP in a nursing home, is it comparable care? Are people getting what we call opiate pumps or CAD pumps, prison pumps, which are just a way of infusing morphine sub-Q? Are they getting the same frequency of visits and durations of contact? So that was our first sort of variation we need to front. So we're now confronting a second variation. So as you go to change the payment system, well, what are people going to do? They're going to try to figure out ways of maximizing their revenue, especially if you're a for-profit hospice program. So this was one of my assignments to do. This is a talk I gave that's publicly available through the Academy of Health. I gave it on the Monday before flying out here. So this is also my very, very, very sick sense of humor. Live discharge, not dead yet. I'll tell you a very, very bad joke, but I'm on a track record for telling you very bad jokes. I always joke around with my hospice team when we have to discharge someone, because discharging someone is an appropriate thing to do for hospice services. Because if you take away terrible medications from people, they get better. You know, I jokingly have always talked about that one of my most favorite hospice interventions is to take off a fentanyl patch, because usually in a frail older person, it can cause opiate toxicity. And I brought so many people back to life by just saying, remove the patch, decrease the opiates, and they get better. So my hospice team sometimes has trouble with the word discharging people, and I jokingly say, well, we're going to give them a t-shirt, and the t-shirt's going to say, I survived hospice, and on the back it will say, this time. Because, you know, they'll come back. The first thing we always need to do is to do good medical care. That's really what our obligation is. So here's what we know about live discharges. Not a lot, but it's an important vulnerability. If you go to change the payment, what people are going to do is they're going to discharge patients alive and recycle them through. So you can imagine them trying to do multiple use. So we need to look at that. So the research on live discharges, they can occur in the US for a variety of reasons. Patients make a decision, medical condition stabilizes, hospices may be avoiding costly medical care. You want to get that CT scan, discharge the patient, readmit them after that CT scan. That would be considered fraudulent care in the US, because a hospice is required for all, they receive a capitation payment for all medical costs related to that terminal diagnosis. So discharging and readmitting is not a good thing. Jean Kuttner, 2004, looked at the reason for discharge in a very small cohort. 79% improved, 7% pursued aggressive care. So the majority of these are prognosis stabilized. And 12% other reasons. Melissa Carlson in Journal of Clinical Oncology used the SEER data set and found 58% died in a month. Now, mind you that she only really looked at a decedent data set. 38% pattern of this churning admission, discharge, readmission, and mean costs were higher among those who were discharged, mainly because there's probably acute hospitalizations where people are pursuing aggressive care. MEDPAC, recall MEDPAC is our Medicare Payment Advisory Commission, looked at live discharges, and they continue to look at live discharge. As of the June report, they looked at live discharges again, and they noted that hospices that were exceeding that cap, that reimbursement cap, were 48% had a live discharge rate when they exceeded the cap. They're discharging patients to try to bring those costs down so they won't exceed the cap, compared to a 16% rate of live discharges below the cap. Now, they combine that with the information that these people are also keeping people on much longer, and they're making the assertion that they were enrolling patients onto hospice at the wrong time. Now, require. The Medicare hospice benefit does not use the word need. It is based on prognosis and preferences. So every week, my job, which I actually did at King's, I went on the computer and I did it at King's this morning, and I have to write a statement that says, I attest that this patient, if it follows his normal course, will have a prognosis of 6 months or less. Okay, that's my job. Yeah, that's what I get paid for, and I'm going to continue to do it until they change it. It's nothing about need. And the patient has to consent to come on to hospice. Well, what's the patient doing? The patient's consenting to say, I no longer will pursue aggressive treatment to promote my survival for that care. Now, they can still receive palliative treatment, but again, well, is chemotherapy palliative? When is chemotherapy palliative, and when is chemotherapy life-curing or life-extending? So therein lies the debate. So one thing which is really very fun in working on a government contract is you get the data a whole lot faster. So I actually have 2010, 2011 data. And usually, you know, I'm still bringing in 2009 data, so this is really a lot of fun. So is this a fire alarm or not? No, okay. I thought for sure we're going to have a break. So we looked at people who were discharged between January 1st and December 31st, and we said we wanted to have at least 6 months of follow-up, so we described. And when we described facility level analysis, we required at least 30 discharges, irregardless of live or decedents. Our job was to document the rate of live discharge, 6-month outcomes, to describe state and hospice facility variation, and then to examine organizational characteristics associated with discharges after adjustment for age, gender, medical diagnosis, being in a rural region, and the 𝐒𝐂𝐔𝐍𝐃𝐄𝐑. Are you familiar with the 𝐒𝐂𝐔𝐍𝐃𝐄𝐑? It's a comorbidity index that is calculated during an acute care hospital stay. So that meant that anybody who had an acute care hospital stay, I had an 𝐒𝐂𝐔𝐍𝐃𝐄𝐑. For those who didn't have a hospital stay in the last 6 months, I basically had a dummy variable in the model to say they didn't have a hospital stay. And we accounted for analysis for clustering of patients within hospice providers. So in 2010, we had nearly 1 million discharges. So as you can see, hospice is majority white, 8% black, average age of 82. We had 3,489 hospice providers who met my cutoff. 18% were live discharge. Does that seem high or low to you?
High.
I don't know. Of those people who discharged, 49.2% were dead within the following 6 months. Okay. So of those people who were discharged alive, 18.5% were admitted to a hospital within 2 days. And then out of that 32,000, 13,000 were readmitted to hospice within 2 weeks of that initial discharge. So those are the churners. Small rate, but still overall, 5 or 6% are churning. Overall, 16% of live discharges were admitted to hospice within 2 weeks. Well, again, thank you. These states are going to keep me working and funding grants for a long time because I ask you, okay, so Connecticut has a live discharge rate of 12.4%. Okay, when you look at all the states seem to cluster around 18, except for my favorite state of Mississippi, Oklahoma, they're all up near 40%. It's 39.6%. I suspect that a 39.6% rate of live discharge is not related to clinical characteristics. That I'd be very suspicious. These are the states that have a high rate of fraud cases. They're states that are highly to have above cap. They're states that don't have a certificate of need. In some of these states, in some of the major cities, you have something like 39 hospice programs. Could you imagine that? You know, how many hospice programs do you have for a city like the size of London? 8, 9? A lot more? 20? So the US version of that probably be 80 or 90. You know, you know, a lot of our programs are these very small programs. Okay, so here's the facility variation. So you can see there are some programs where the 99th percentile rate of live discharge is 99, it's 73.3% to a low of 5.9%, 25th, medium 75th. This is the rate of hospital admission and the rate of coming back to hospice within 2 weeks. So obviously we have an outlier problem here. So there are some problems where we need to look at what's going on with this rate of churning. So this is now the multivariate results. So for-profit versus not-for-profit. In the US, the fastest growing type of hospice provider is a for-profit hospice. And it's a for-profit hospice that's usually a chain. So you can see the rate of live discharge was 15.3% in not-for-profit, 21.5%, and about adjusted odds ratio 0.87. Rural, 19.4 versus 17.2. Older hospice program versus younger hospice program. Really is a huge story there, 14.9% versus 25.5. We decided to explore that a little bit more and try to tease out the for-profit versus the not-for-profit. So young, for-profit rate, 29.5%. Now, which state do you think these are in? My favorite states. That's where they are. Even in the not-for-profit, it's 20.4%. Larger hospice program, this is greater than 1,000 admissions per year, 17 years of operation, 14.8 to 15%. So mature hospice programs who have survived the time, have not been kicked out of the Medicare Hospice benefit for fraud, seems to be operating okay. It's these younger for-profit hospice programs that seem to be causing the problem. So I think one of the difficulty of live discharge is we expect some live discharge. You know, it used to be back in the dark ages, before every hospital had a CT scan and MRI in their emergency room, that if you met a surgeon who had not operated on a live appendix or on a normal appendix, you probably would meet a surgeon who's missed a burst appendix. Well, same thing. We want to probably, for access, bring these people on, and if we can fix things, do good care, send them back, stabilize them. Don't keep them on hospice services. We want to, provide the appropriate care. So we wouldn't expect the live discharge rate to be 0. Now, would we expect it to be 50%? Would we expect it to be 40%? Would we expect it to be 30%? Would we expect it to be 20%? That's really the difficulty. Now, how much is this explained by patient preferences? I don't think patient preferences are driving this. I think there are really some unique circumstances we need to understand. But if I was thinking from a policy standpoint, this substantial variation by state and by facility and the concern with younger for-profit hospices would let me make the recommendation that as you're modifying the payment, this is something you have to watch very closely. This is a potential vulnerability, and it's a vulnerability that you may want to make a policy intervention ahead of time to really think about. So I can tell you we've been looking at payment for related illness. Our first thing that we've already published and released in the Federal Registry is there are some hospice programs that don't pay for opiates. And the opiates they don't pay for are the expensive ones, and this varies substantially. It's a problem. There are hospices that do the cycle of churning, discharge to hospital and readmission. Again, varies substantially. So I think this is one of the times where we have to really think about what it is we're doing, why we're doing it, and are we really understanding what patients need? Because that really is the ultimate arbitrator of what we do. So let's talk about some of the challenges. Aging imperative. It's not uncommon to have a 109-year-old on service now. It used to be 20 years ago, 101 was unusual. I have people now who are 109, 110 years old. And a lot of these people don't fit into neat diagnosis. Really, they're frail. It's fragility. But fragility under ICD-9 is not a diagnosis, it's a symptom. So what do you call these people? I have to give a diagnosis to people. So, what is their terminal diagnosis? I can't say old age. Dementia and non-cancer diagnosis have a very different disease trajectory. Recall the Medicare Hospice benefit was created based on a cancer model. We paid on a cancer model. That's why we're seeing this very different rate of wage minutes of what is needed to take care of these people. It is not all clear to me that we need a full multidisciplinary team to take care of dementia patients throughout their entire disease course. If they're actively dying, we probably need it. But do we need it for this period of time when they're slowly losing weight? I think we need to think about that. We need to think about a model that we developed for cancer and how do we apply it to these non-cancer diagnoses, especially around dementia. I think we have to be open to newer models. 2008, we have to get healthcare spending under control. That's the bottom line. You know, the emphasis, at least from a U.S. perspective, is they want that cost curve down. They want healthcare spending to start reduce. It's coming down to a choice of schools versus healthcare dollar spending, and we really need to start constraining costs. We have fragmented our healthcare system to so many silos. We have to figure out how to make it work. I don't know about you, but we now have hospice, which you're probably familiar with, but we have intensivist, we have sniffist, and I've decided if you want to be a doctor in the future, you have to add an IST to your name. Well, all this does is it gives a lot of doctors a lot of handoffs and a lot of chances for medical errors. And really what we need is to enhance continuity of care and care coordination. Now, as I say these things, and as we go upstream with palliative care, we should not forget the reason why we came into existence. Because hospitals were doing such a terrible job of managing actively dying patients. We cannot forget dying patients as we go into non-cancer. So we have to be able to hand the duality. It's a very different decision making that you think about in an actively dying patient. I was on call 2 weekends ago, and I had someone who was just training to become a hospice physician with us, and I gave someone 5 milligrams of Haldol for acute agitation and gave a Q1 hour order, and the person looked at me like I was cross-eyed. She goes, well, I would never start anything but 0.25 milligrams of Haldol. And you know what? Actively dying patient, you need different doses of medicines to deal with extreme agitation, and sometimes you have to be prepared to use. I'm not saying that's my starting dose all the time, but I have to stabilize that situation at home really quickly if I want to get that patient to die at home. It's a different type of decision making, and we need our nurses, our physicians, our team to understand who is in this up-down syndrome and who is now actively dying. Really, what's amazing to me is the recognition of actively dying. It's really one paper that was published in JAMA a long time ago. It had only 100 patients in it. That's the only place where we get median survival for the symptoms that we see every week in taking care of someone actively dying. The challenges. This is our to-do list. We need physicians, nurse practitioners, nurses, social workers to become critical thinkers. We need them to be able to ask the risk-benefit ratio of when do you order labs. We need to deal with the world, at least in the US, everything is going to become bundled. And that means I have to really think through when do I need just that palliative care nurse practitioner or that palliative care doc? When do I employ the full IDG? And how do I dial up and dial down that intervention? And how do I get my staff over it when to think about this? I think we've got to be transparent. Okay, we went through this whole thing about death panels. We had someone who I will refer to as the village idiot really derail us for a year. And you know, in terms of like, you know, I would go and I would say, oh, we can't talk about advanced directives because of death panels. Well, fortunately, we're now talking about advanced directives. We are actually mentioning the D word. But I think really we have to be very transparent to the public on what we do, what our outcomes are, and we have to be committed to improving. When we have variation like we see here, we have to improve that variation. We have to understand that variation. The other thing we need to do is we're going to be more and more involved in difficult conversations. Okay, reviewing hospice IDG. I admitted several patients. I take care of a care home team, and all these people are admitted to hospice with dementia. Why are we still giving them Namenda? course, you realize the fact that I'm saying this means I will no longer work for CMS. But I really think we have to ask that question. Is it clinically effective care to give someone with advanced dementia who's end stage all these drugs?